Respiratory distress is one of the most common and life-threatening clinical presentations nurses encounter in both hospital and aged care settings. For new graduate nurses, understanding how to assess, identify, and manage respiratory distress is critical to preventing deterioration and ensuring timely escalation. This topic will explore the normal respiratory function, common signs of respiratory compromise, assessment techniques, clinical interventions, and escalation pathways. Mastery of this knowledge helps you build confidence, competence, and clinical judgment in a fast-paced healthcare environment. The respiratory system is responsible for gas exchange, delivering oxygen to the bloodstream and removing carbon dioxide from the body. It involves the upper airway, lower airway, lungs, alveoli, and associated muscles, such as the diaphragm. When respiratory function is compromised, oxygenation and ventilation are impaired, resulting in signs and symptoms that require immediate attention. Nurses are often the first to notice changes in a patient's breathing pattern, respiratory rate, or oxygen saturation. Early recognition is essential to avoid respiratory failure, cardiac arrest, or other complications. A typical respiratory assessment includes observing the patient's breathing pattern, auscultating lung sounds, measuring respiratory rate, assessing oxygen saturation with a pulse oximeter, and asking about subjective symptoms like shortness of breath, chest tightness, or anxiety. You must also observe for accessory muscle use, cyanosis, nasal flaring, or tripod positioning, all indicators of increased respiratory effort. Tachypnea, rapid breathing, bradypnea, slow breathing, or irregular breathing patterns should always be considered red flags. One of the first steps in managing respiratory distress is ensuring the airway is clear and patent. For conscious patients, encourage deep breathing, repositioning, and reassurance. For unconscious or semi-conscious patients, a head tilt, chin lift, or jaw thrust maneuver may be needed. Suctioning may also be required for patients with copious secretions or who are unable to clear their own airway. Administering supplemental oxygen is one of the most immediate and effective nursing interventions. The delivery method depends on the patient's needs and condition. A nasal cannula provides low-flow oxygen for stable patients, while a Hudson mask or non-rebreather mask delivers higher concentrations. In emergencies or severe hypoxia, a bag valve mask may be used. It's important to monitor oxygen saturation levels and adjust flow rates accordingly while being cautious with patients who have chronic respiratory conditions like COPD, where excessive oxygen can suppress the respiratory drive. Listening to lung sounds using a stethoscope helps identify conditions like pneumonia, pulmonary edema, asthma, or bronchospasm. Crackles, rales, wheezing, and decreased breath sounds can provide insight into the underlying cause of distress. Comparing left and right lung fields and noting changes over time are important documentation and communication points. Arterial blood gases, ABGs, and chest X-rays are common investigations ordered by doctors, but nurses should be familiar with what they mean. An ABG may show hypoxemia, low oxygen, hypercapnia, high carbon dioxide, or respiratory acidosis/alkalosis, helping clinicians understand if the problem is related to oxygenation or ventilation. Nurses may be responsible for preparing the patient, assisting during sample collection, and managing post-procedure care. Escalating care is crucial. If your patient shows signs of respiratory deterioration such as increasing oxygen requirement, altered consciousness, or dropping oxygen saturation despite oxygen therapy, activate the Rapid Response Team or MET, Medical Emergency Team. Use structured communication tools like ISBAR to ensure all relevant clinical details are conveyed to the team clearly and confidently. In patients with chronic respiratory diseases like asthma, COPD, or interstitial lung disease, management may involve bronchodilators, such as salbutamol, or anticholinergics like ipratropium. Nurses are responsible for administering nebulized or inhaled medication and assessing the response. You must also monitor for adverse effects such as tremors, tachycardia, or anxiety that can occur with beta agonist use. Some patients may be on advanced respiratory support such as CPAP, continuous positive airway pressure, or BiPAP, bi-level positive airway pressure. Understanding how these machines work, how to troubleshoot them, and how to assess patient tolerance is essential. You should work closely with respiratory therapists or clinical educators to gain hands-on training in using these devices safely. Another important aspect is documentation and communication. Every respiratory assessment should be recorded thoroughly, including respiratory rate, effort, oxygen delivery device, SPO2 reading, and response to interventions. Accurate documentation not only supports continuity of care but also provides a legal record of your clinical observations and actions. Nurses also play a key role in patient education. Teaching patients how to use incentive spirometers, how to breathe effectively, and how to manage their chronic lung conditions at home supports better long-term outcomes. For patients with asthma or COPD, ensure they understand their action plans, medication use, and when to seek emergency care. In the aged care setting, respiratory distress may present subtly, with confusion, decreased appetite, or lethargy instead of typical breathlessness. Being aware of these atypical presentations is crucial for early recognition. Older adults may also be more vulnerable to respiratory infections, such as influenza or pneumonia, and preventive measures like vaccination and good hand hygiene should be encouraged. Interprofessional collaboration is vital. Nurses must communicate effectively with doctors, physiotherapists, and respiratory therapists to ensure comprehensive care. You may be involved in arranging chest physiotherapy, monitoring during procedures like bronchoscopy, or supporting palliative care patients with end-stage lung disease. Ethical considerations also come into play when managing patients who may not benefit from aggressive interventions. For example, in patients with advanced COPD or malignancy, discussions around goals of care, advanced directives, and comfort measures must be handled with sensitivity and professionalism. In summary, assessment and management of respiratory distress require a strong foundation in respiratory anatomy and physiology, skilled observation, prompt action, and clear communication. For new nurses, becoming confident in this area involves combining textbook knowledge with clinical experience and ongoing education. With time, you'll learn to spot subtle changes, trust your clinical instincts, and intervene quickly to prevent deterioration. Respiratory assessment is not just about checking numbers, it's about looking at the whole patient, thinking critically, and responding with compassion and competence.